Let's start. Bon dia a tothom, benvinguts. Welcome to this third Global Health Lecture that is organized by the Alliance of CRECIB, CREAL, and IS Global. As you know, we have been working together with, between CREAL, CRECIB, and IS Global to create this new Global Health Institute. And as part of the transition, we are organizing several activities, scientific activities, and organizational activities, and one of them are these Global Health Lectures that we invite distinguished scholars to come and talk here or at the clinic. And today we have Dr. Chris Wild, who is the director of the International Agency for Research on Cancer. We have been working in this alliance for now about a year and a half, and it's complex because always when you are merging two institutes, it is not easy, but it's going really well. It's going quick. We have full support by the Generalitat, and so we are really optimistic that things are going very well. And as I said, among the activities we have are these lectures. So, Chris, well, first of all, I guess, happy birthday, Chris. So it's his birthday today. Okay. So Chris did his PhD at the University of Manchester, then he was as a postdoc here in a couple of places, and then he came to the agency in the mid-80s, and eventually he was the chief of the unit of environmental carcinogenesis. Then he went to Leeds, and he eventually became the director of the big Leeds Institutes of Genetics, Health and Therapeutics. And then in 2009, he was elected director of the International Agency for Research on Cancer. And he was re-elected for a second term last year. And this was really good, basically, because he has given a really new impetus to the agency, and which is is a very important agency. His main research institute is related to the interplay between environmental and genetic risk factors, and actually he's the one who, for the first time, presented the concept of the exposome. And we are very much into the research in the exposome. He has been working for a long time in using biomarkers in population-based studies in relation to liver and esophageal cancer, and he's responsible for the big trial that happens in the Gambia hepatitis intervention study. So, Chris, thanks a lot for coming to these lectures.
Thank you. Okay, well, thank you very much, Manolis, for that kind introduction, and it's a pleasure to spend my 21st birthday in Barcelona. Huh? Well, I'm really pleased for two reasons. I'm particularly pleased to be here today. Actually, the first is I think I came about 6 or 7 years ago, actually, for a meeting. And at that stage, I was shown around the building, and mostly it was empty offices. And now I walk around and everything is thriving, actually, and there's a real nice buzz around the place. So it's a pleasure to just get a feel for how the Institute has progressed. And the second reason I'm really pleased to be here is that I'm from Manchester, but Manchester United. So I was cheering on Barcelona the other night against our rivals. Okay, so if I could, do I need to put the slides on? Or, oh, no, I messed it up. Which is the way to, no? Oh. Oh, he's coming down. Okay, sorry. Now I messed it up. Okay. Well, now I just proved that I'm not 21. Technology is beyond me. Sorry. Yeah. Okay. Good. Okay. Thank you. So my goal, I had thought a lot about what to present today, and given the interests of the Institute and the way this merging is going with the issues around global health, I thought I'd talk about global cancer control, just what the situation is in terms of cancer worldwide, but also some ideas on the approaches we need to take to combat this burden. Our agency, as Manolis mentioned, it's International Cancer Research Agency, part of WHO, and we've really decided that our focus is on cancer research for cancer prevention. But what we mean by prevention is just summarized on this slide. First of all, describing the occurrence, so understanding the burden and the patterns of cancer. And this, of course, helps in governments in cancer control planning, but it also gives us clues to the causation of the disease. Then we do a lot of research into etiology globally, trying to establish the causes and also evaluating carcinogens through the IOP monographs program. Then we do research into prevention strategies, evaluating preventions. It might be screening programs or vaccination programs against oncogenic viruses. And then increasingly, and I think a very important area of cancer research, is supporting implementation. Once we know that something will work in principle, how do we really get this into practice in a healthcare setting, particularly in low and middle income countries? So what I'm going to do is spend a little while talking about the scale of the cancer problem, then about how we should implement what we already know in terms of cancer prevention, and then some thoughts about how we might address what we don't know. Cancer is an important cause of mortality and premature mortality. What I'm showing here is different age groups, and if you look at the central panel there, 30 to 69 years old. 30% of premature deaths due to non-communicable diseases are due to cancer in that age group. And the United Nations, and with WHO as the lead agency, has been tasked with this target of reducing by 25% the premature mortality from NCDs by 2025. So this 25 by 25 target. And this is important because a lot of the governments now are focused on non-communicable diseases, and including cancer, in relation to this target. If we think then about the specific cancer burden, so the agency just published the new estimates, GloboCan data. So in 2012, 14 million new cancer cases worldwide was the estimate we have, just over 8 million deaths. I think also important point about prevalence, over 32 million people living within 5 years of a cancer diagnosis globally. So it's very important, I think, for governments to have information not only on how many people are developing the disease and dying from it, but also living with it. And these figures are made from the best estimates we can have from cancer registries worldwide. If we think about what types of cancer are dominating the picture globally, this is the incidence. Lung cancer, you can see, breast, colorectal, prostate are the most common cancers on a global scale. Just draw your attention to stomach and liver, which are down there in the 6th and 7th places, respectively. If we look at mortality, the picture is somewhat different. So now you will see that liver and stomach are the 2nd and 3rd most common causes of cancer death worldwide. These, of course, are cancers that are occurring very frequently in the low and middle income countries, and for which the prognosis is extremely poor. But almost 20% of all deaths from cancer worldwide linked are lung cancers, and of course the vast majority of these associated with smoking. We think, where does the burden fall in terms of geography? The green parts of these pie charts are Asia, East Central Asia, India and China broken out separately. And in fact, around 60% of all cancer cases and 65% of cancer deaths are now in the low and middle income countries, in the developing countries. Of course, the populations are larger in those regions, but in terms of burden, this is where the cancer burden is increasingly falling. You can look at it another way in terms of human development, and we use now this Human Development Index, which is a composite of not only life expectancy, but educational attainment, as well as economic position of the country. And actually, it's no longer just a very simple geographic spread, but you can see that the low and medium Human Development Index countries, predominantly sub-Saharan Africa, Central, Eastern, and Southeastern Asia, but parts of Latin America as well. If we look at the disability-adjusted life years lost to cancer by Human Development Index, estimate is that there's 168 million years of healthy life lost in 2008 due to cancer. And more than 90% of this is actually years of life lost. So it's not so much living with the disability, but premature death from cancer. And if we look at this by Human Development Index, I think this is interesting. This is now expressed per 100,000 years of life. And what you can see across the top here are just the DALYs, the total in the dark blue, and the years of life lost in the dark red. And this is showing really across all levels of Human Development Index. This rate is quite similar already. And that's because, particularly in the low and medium HDI regions, the cancers are occurring relatively early, and the survival from cancer is much poorer. So this leads to this impact on the population, which is already really present. And the bars at the bottom show the years living with disabilities. This makes a relatively small contribution overall to the DALYs. So cancer is certainly a global problem. I just had to give an interview to one of the newspapers here, and one of the first questions was, you know, cancer is a disease of wealthy people, but this is clearly not the case. So it's a global but not uniform problem. And this slide is just showing the most common cancer for each country in the world. And I think what you can see is certainly for men, the predominance of prostate cancer. Even in parts of the world we might not think of having high rates of this particular cancer. The dominance of lung cancer in many parts of Asia and Eastern Europe, Central Eastern Europe. But look at the pattern for women. I mean, breast cancer now, the most common cancer among women in 142 countries worldwide. And really just parts of Latin America, Sub-Saharan Africa, where cervical cancer is still the most common. In fact, breast cancer is responsible for 1 in 4 of all cancers among women worldwide. And even if you take both sexes together, 1 in 5 cancer survivors is a breast cancer survivor. So I think if, as an international agency looking globally, one of the biggest challenges we have is to tackle the burden of breast cancer, and particularly how to detect this cancer early in parts of the world where programs of mammography-based screening programs are simply not feasible at this time. Okay, this slide's probably a little bit complicated, but what I'm trying to show here are the 5 most common cancers by level of human development. And probably the things to point out, just the predominance of breast, prostate, and lung in the higher Human Development Index. And then the way we have some of the infection-associated cancers, cervix, liver, stomach cancer, being more common in the medium and low HDI countries. If we return just for a moment to breast cancer, I think this slide is very striking, actually. So here on this slide, you have the incidence of breast cancer by geographic region and also the mortality in red. And you can see that whilst the incidence is 2-3-fold higher in many parts of Europe than it is in parts of Asia and Africa, In fact, the mortality rates, the age-standardized rates, are not dissimilar. So this really illustrates the poor survival, even from a cancer which is eminently controllable, curable in many parts of the world. This high mortality rate, lack of access to care, and late diagnosis in many parts of the world. So that's the picture in 2012. What about moving forward? So the Globocan also allows some projections to be made, and these projections are simply based on demographics, on the aging and population growth. So here we are in 2012, and the estimate is that by 2030, we have just under 22 million new cases and 13 million cancer deaths. So a huge progression, only based on the demographics. If you superimpose on this some changes in risk factors, the limited work we've done on this is that these could be conservative estimates. And again, this is not linked to just one part of the world. Again, if we look by this Human Development Index, in fact, the percent increase is greatest in the countries which are at the lower end of the Human Development Index. So you can see almost 90%, almost a doubling in the number of cancer cases in the low HDI countries over the next 20 years, just based on demographics. So as an international agency, I mean, this really indicates that we need to focus on some of those low and middle income countries, but also that we can't address this only with improved treatments, and I'll come back to that soon. It's not a static picture either. So these are data from reliable cancer registries over time. What I'm showing here are just some changes in incidence of breast in blue and cervix cancer in red over a period of some 2 to 3 decades. And what we see is this pattern of increasing breast cancer incidence and decreasing cervical cancer incidence. An exception here in Uganda, where the breast cancer is going up and also the cervical cancer, possibly linked actually to the very high HIV infection rates in this population, making women more susceptible to human papillomavirus. And in fact, colorectal cancer, which is shown on this slide in blue, plotted along with the change in Human Development Index within the country. So in Australia, China, Colombia, and Uganda. It's almost a very nice measure of human development is the colorectal cancer rate in the country. So I think the message to governments in this respect is that this picture of cancer in the countries is not static. And one has to be thinking forward in terms of cancer control to the patterns of cancer that emerge as the country undergoes development. And so in summarizing this, we see certain patterns in the very high Human Development Index countries, breast, lung, colorectal, prostate. We see some of these infection-associated cancers in the medium and high. But in those in transition, the decreases, some of the infection-associated cancers, are more than offset by increases in cancers associated with a more industrialized lifestyle. So my first major conclusion, I suppose, from looking at these data is that we cannot hope to treat our way out of the cancer problem. And that's actually true globally, but even more pertinent in the low and middle income countries. And so we really need a much more balanced, integrated approach to prevention, early detection of cancer, and treatment. And this really has big implications for where also investment is put in terms of cancer research and cancer control. So let me talk a little bit now about implementing what we know. I mean, various estimates have been made of the proportion of cancers that could be prevented based on current knowledge, but a reasonable estimate seems to be around half of all cancers. just by applying the knowledge we now have on risk factors. But at the same time, we know the majority of cancers have a lifestyle or environmental etiology. So the potential actually for prevention is much greater. Well, this is completely illegible, I guess, but this was to tell you two things. I mean, first of all, the IARC monographs evaluate the causes of human cancer, and you can access all this information online, download the monograph reports. They're a useful source of background information. And we're also trying to integrate this information with other databases on the global occurrence of cancer and the WHO classification of tumours. And there was a paper in JNCI on this recently. But, you know, if we think about what the major cancer risk factors are globally, there's been a lot learned over the last 50, 60 years of epidemiology, cancer epidemiology. Of course, we know about tobacco, and there's a number of challenges there in terms of particularly implementing the WHO Framework Convention on Tobacco Control and the impact of taxation, bans on advertising, and so on. Infections responsible for about 1 in 6 cancers worldwide, and again, we have the success of some excellent vaccines against hepatitis B, human papillomavirus, alcohol, and increasingly understanding of physical inactivity, overweight and obesity in terms of cancer risk. Of course, the knowledge we've gained about various types of radiation, including sun exposure, environmental and occupational carcinogens, and also reproductive factors and hormones. So, I mean, a huge amount of information on risk factors for cancer, giving us avenues to prevention. And I think one of the key messages here that this needs a combination not only of education and action at the individual level, but also at a government and societal level to really tackle cancer and promote cancer prevention. So when a country is looking at prioritizing cancer control measures, all things are not equal. So I put this one up just as an example. This is the regional variation in the proportion of cancers related to a chronic infection. And you can see that whilst in sub-Saharan Africa, 1 in 3 cancers is associated with an infection. This is about 1 in 30 in North America and in Australia. So therefore, the decisions about where to invest in cancer control are going to be quite different depending on the profile of risk factors. Complementing this primary prevention, because of the natural history of cancer, of course, there are opportunities for early detection and treatment for breast cancer, cervical cancer, colorectal, and in some high incidence regions, this is also relevant for oral cancer. And I just make a note here that the agency will review in November this year the evidence on approaches to breast cancer, early detection and screening. And I think this will be really important evaluation, not only of mammographic-based screening, but also things like clinical breast examination, breast awareness, and other approaches that might be more applicable to the low and middle income countries. In trying to make the case for prevention, it's really important to understand that it does work, but it takes time. And I tried to illustrate this on this slide for lung cancer and cervical cancer. Lung cancer with tobacco control, and you can see here these are just incidence data from different countries from the late 1970s onwards. And you can see these dramatic falls in lung cancer incidence in the UK, Finland, the USA here, as a result of reduced cigarette smoking. And this is cervical cancer. You know, here's the rates in Finland and the incidence rates in the UK, Norway, and so on. So it's interesting, if you look at the cervical cancer rates in Finland 50 years ago, they were actually very similar to countries in sub-Saharan Africa today. So this has been controlled by screening, early detection, and treatment of precancerous lesions. And in fact, if you look at some of the Eastern European countries, Romania, Bulgaria, their cervical cancer rates today are similar to some of the sub-Saharan African countries today. So by interventions, both primary and screening interventions really works, but it needs political vision and it needs leadership and time. And this is an example, some modeling work, not from our agency, but published in JNCI just recently, looking at the reduction in squamous cell carcinoma of the cervix with introduction of human papillomavirus vaccine. And again, you can see really taking maybe 25, 30 years before you see an impact on the cancer incidence in the population. So again, it's important to start, but it's important to get the message across that this will take time to see results. So I'd like to just spend the last part of my talk addressing what we don't know about cancer control and some ideas on areas that might be profitable for future research. And this slide could generate some argument, actually, but I put it up for a purpose of illustration. I mean, I've listed here some cancers where I would argue the causes are largely unknown. I mean, prostate cancer, one of the most common cancers in the world, I think we don't have a single major risk factor identified for this disease. And then I've put a number of other cancers for which I think, again, I can make a good argument that we know very little about the etiology. This is not to say we don't have any, I mean, we can take kidney cancer. Obesity is associated with an increased risk of kidney cancer. But in terms of explaining the overall burden globally, we know very little. So there are a number of cancers for which progress in understanding the causes has been limited. So how do we address this? How do we move forward? And this is where I think there's an opportunity for the excellent advances in the basic science, understanding mechanisms of carcinogenesis over the last couple of decades to benefit population-based research. So clearly, this is finding its way into the clinic, and the promises of tailoring the treatment to the particular characteristics of the tumor by stratified or personalized medicine. But I would like to make an argument in the rest of my talk that there's an opportunity also at the population level. And I think increasingly we understand that these are not separate processes. So in fact, the risk factors that drive the development of the cancer lead to specific molecular alterations in the tumor, which in turn influence the response to treatment and the prognosis of that patient. And a lot of the laboratory methodologies that have been developed to understand the development of cancer are applicable, actually, to the sorts of biospecimens we can collect in population-based studies. And particularly these sorts of approaches are suitable for application in cohort studies, prospective cohort studies, looking at cancer in relation to a variety of risk factors. And I just take a slight detour at this point to point out that these methodologies are also allowing us, I think, for the first time, to ask questions about the impact of an exposure early in life on the risk of cancer or other chronic diseases in adulthood, and seeing whether those exposures really change the biology in that individual such that they're more susceptible later to cancer and other chronic diseases. So I'm just going to spend a few minutes giving a few examples of where I think there are fruitful areas for bringing the lab science to bear on the population-based research. And first of all, I just talk a minute or two about exposure assessment. So I've said already that we have this link between environment and lifestyle. We know that exposure measurement is problematic in many situations. And yet we're investing hugely in these large-scale prospective cohort studies to answer questions about environment, lifestyle, genetics, and chronic disease. And this is where I think Manolis mentioned at the beginning about the exposome and this idea to complement the fantastic tools we have for interrogating the genome with an equivalent set of tools to interrogate environmental and lifestyle exposures. And I was interested in your pronunciation, so you said exposome. So I think in the States, I was at a meeting to discuss this, and somebody asked me the question, you know, is it exposome or exposome? So the Americans say exposome. So I was reminded of a conversation between my secretary in Lyon many years ago and a Canadian postdoc who were arguing in similar vein about how to spell esophagus. And the Canadian was saying it was with an E, and the English secretary was saying it was with an O. And the concluding argument was, from the secretary, was, we've been writing esophagus a lot longer than you have, so it's an O. So this is my concluding argument for exposome and not exposome. So I want to also insist on the fact that biomarkers are just one response to this need to improve exposure classification. And there are many others, and I know a lot of interesting work going on in this institute exploiting some of these other technologies. I mean, the goal is to improve the measurement. It doesn't matter which technology is brought to bear on that. But let me just give you some examples that I think are quite exciting. And this is an example actually from just using smokers as a model system to look at the expression of different genes in the bronchial epithelial cells, so the target cells, if you like, for carcinogenesis. And these investigators, without going into the detail of what looks even more complicated up here than it did on my laptop, actually, the message here is that it was clear that there were certain genes expressed very differently in smokers compared to non-smokers in the epithelial cells. And actually, other work has gone on to show that some of these changes are quite persistent and others are reversible in non-smokers. The reason it's important, I think, is just the proof of principle that the exposure leaves a fingerprint on the gene expression pattern. And this may give us some source of information to classify exposure. That's been similarly addressed with for example, looking at methylation in promoter regions of specific genes. Some work from my colleague Stenko Herseg in Lyon. I mean, they were doing studies on liver cancers, looking at the progression of the tumor, different histological grades in relation to gene promoters which were methylated or not. But they did have some information on risk factors, so they asked the reverse question whether, if they stratified the cancers by exposure, did they also see different patterns in methylation of these gene promoters? And the answer was yes, that individuals exposed to hepatitis B had different pattern than alcohol-exposed or HCV-exposed individuals. So again, very preliminary type work, but it just shows in principle there is evidence about the exposure present in the tumor, in this case, the liver tumor. And I'll just show you one example which I think is illustrating how this field may go forward. So in the agency, along with collaborators in different centers, we've been looking at the mutations in renal cell carcinomas. So actually very high incidence of this cancer in parts of Eastern Europe. So across these four populations, same histological type of tumor was collected. And all I'm showing here are just very crudely the base pair changes from whole genome sequencing of cancers from these different populations. And these are here perhaps just look at this green band here. These are A to T mutations, base substitutions. And you can see a very different pattern, I think, in the Romanian tumors. And this is now repeated in a second set of cancers. Very different than the pattern in the other three countries. And actually, this is a rare mutation pattern. And where it has been seen previously is in upper urothelial tract tumors, and particularly from regions of the world where there are, in the Balkan region, where there is contamination of cereals with wheat producing, contaminated with this aristolochic acid. So this is a known human carcinogen, but it's been associated with these rare urothelial cell tumors. But what we see here are renal cell cancers from the same region, but showing the same pattern of mutation. So I think this is really a first study in our experience where we have an unanticipated carcinogen fingerprint associated with a very different tumor type. And for me, it illustrates the potential to get new clues from the genetic analysis of the tumor, which leads us back to conduct new epidemiological studies about etiology. We're also trying to just use techniques like metabolomics to get better biomarkers of diet, and some of the work in the EPIC study, we've been able to select individuals with very high or low consumption of different coffee, for example, red wine, citrus fruits, and then shown that the polyphenols present in the urine samples of these individuals are quite different. And there seem to be some of these metabolites that are really characteristic of heavy coffee drinkers or red wine drinkers and so on. So it's another way of taking a technology, this time metabolomics, into the sorts of specimens we have available in epidemiological studies to improve our biomarkers. Okay, so I'm going to go quickly just through some other examples, because I think this technology can help this approach, not only in exposure assessment, but some other aspects of establishing the causal link between exposure and disease. And one is biological plausibility of an exposure disease association that we may see in epidemiology. And I tried to just pick some examples from the literature to illustrate this. And this is, I think, a very interesting one. This is studying the association between alcohol and oral cavity cancers. And this is an experimental study, but using biomarkers. Subjects consume different amounts of ethanol using a mouthwash to then obtain DNA from the oral cavity. And what they were measuring were DNA adducts associated with acetaldehyde exposure. And again, it's just really, I think the detail of these examples is not important. I'm just trying to illustrate the type of study one can envisage. And here you can see after the lowest level, exposure, the intermediate and the high level. I mean, here we have, up to 100-fold increase in DNA damage in the cells of the oral cavity after this alcohol exposure, with considerable inter-individual variation. So I think for me, this type of experimental study in people can really complement the epidemiological studies linking exposures to risk factors. Another big opportunity we have is to stratify risks by tumor subgroup. And I mean, as you'll be aware, that the work that's come out recently, the last year or two, on breast cancer, large studies. I mean, in this case, this was an example, over 2,000 tumors from Canada and the UK, where the investigators were primarily trying to link novel molecular subgroups with distinct clinical outcomes. And of course, the goal there is to find new subgroups that could be targeted with specific treatments. But from an epidemiological perspective, I would ask, are there any implications in terms of studying breast cancer etiology with this type of molecular subclassification? And so what we're trying to do at the agency is to use our international opportunities to exploit this. So we're collecting breast cancer cases from different Latin American countries, conducting an epidemiological study with risk factor assessment, but also the biological specimens, which will allow us to study at the molecular level the association between exposure, and not just the disease, but the subtype of those tumours. And this type of biomarker can also help us in evaluating interventions. And I tried to put something in my own research, and also because I thought there may be some interest in some global health questions here. So this is a work we've been doing for a number of years on aflatoxins. So these are contaminants produced by fungi that grow on staple crops in many parts of the developing world. They cause acute liver disease, and a number of people die from acute aflatoxicosis. Very well established liver carcinogens, but also more recently we've observed impairment of child growth in relation to exposure to these toxins, particularly after the child is weaned onto solid foods. So just show some data here. So we developed a very nice biomarker of this carcinogen bound covalently to albumin in the peripheral blood. And this has been a hugely useful biomarker of exposure. And what I'm showing here is a cross-sectional study in the Gambia, West Africa, where we saw an association between the level of exposure to aflatoxin and the degree of stunting, in this case on the left here, and weight for age on the right. And we were able to use that same biomarker to follow a small cohort of children, 200 children over time, over a period of just under a year, classify their exposure based on the biomarker, so from the lowest quartile to the highest quartile of aflatoxin exposure, and look at their growth trajectory. And you can see again there was a very strong association between higher level exposure to this carcinogen and impaired growth in these young children. This is interesting because in the veterinary field, the big problem with aflatoxin is not liver cancer, it's growth impairment of commercial animals fed contaminated grain. So I think here what we're seeing, these levels of exposure are so high that I believe we're also seeing these effects in young children in these populations. But in terms of intervention, how can we use our molecular markers? So we knew in Guinea and West Africa, the major source of aflatoxins are peanuts, groundnuts, harvested in September, October time, and then stored and consumed throughout several months. We had the biomarker. So we decided to do an intervention study, an educational intervention, and ask whether in the intervention villages we could use the biomarker to demonstrate a decreased exposure to this carcinogen. This is some of the typical sort of storage facilities for the peanuts there. You know, most people are using these discarded rice bags. I mean, if you want to grow aflatoxin, you would put it in a plastic bag, high humidity, temperature, and let it sit for a few months, which is exactly what happens. People dry the peanuts on the ground. I don't know if this shows up very well, but you get the humidity from the earth comes into the peanut shells before storage. So we provided these natural fiber mats for drying. We provided wooden pallets to get the crops up off the floor of the storage facility, and natural fiber jute bags instead of the plastic discarded bags. We also worked with agricultural extension workers on hand sorting, removing visibly mouldy peanuts before storage as well. And we put some insecticide on the floor of the storage facilities because one of the problems is insects getting into these bags and creating further humidity and transferring the fungus around the store. Anyway, but the point for this lecture really is that we then were able to look using our biomarker at the level of exposure in these two sets of villages. And these are the control villages here. So we see post-harvest similar levels in control and intervention, which suggests the randomization was adequate. And then this increasing exposure with time as the fungus proliferates and produces the toxin. And this is the result in the intervention villages. So we had about a 50 to 60% reduction in the level of exposure in the intervention villages. And when we looked at the percent of subjects that didn't have detectable aflatoxin in the blood, again, at the end of the study in the control villages, this was about 2% of subjects, classic picture for West Africa, but about 20% in the intervention villages. So again, I think the detail of this study is not important, but the point is that we have these biomarkers which can act as very nice intermediate endpoints in testing out whether some of these interventions have any potential. So if I just take 2 or 3 more minutes and then I'll finish. I just want to then make one last point, really, before I close. And that is my conviction that there is an area of cancer research which is really neglected and which I've termed here implementation or operational cancer research. I mean, that study with aflatoxin was quite satisfying to see this impact of this educational package. But you saw it was published in, I think, 2005. So since this time, no change has occurred in Guinea in the way peanuts are handled and stored and so on. So, you know, for me, there's a big gap between demonstrating a proof of principle and actually implementing in a particular setting any type of cancer intervention. So let me give you an example of the sort of study we're now trying to do at the agency. This was a completely different topic, colorectal cancer screening in Thailand. So the Thai government have seen that with development, colorectal cancer will increase. There is a screening test with fecal occult blood test. So they wanted to implement this countrywide, but they decided to start with a demonstration project in the north of the country in Lampang province. And they asked the agency to participate and build in an observational study into the rollout of the screening test. And our goal was to look at the acceptability, feasibility, the organization of the project, of the screening. And so there were about just under 130,000 subjects invited to participate. Only 63% participated. This is quite typical, actually, of Europe for this particular screening test. And then there were about 1% tested positive, of which 2/3 of the subjects actually returned to undergo the diagnostic colonoscopy. And we learned a lot, actually, about the profile of subjects who participated, who then did or didn't come for the diagnostic workup, and also about the capacity of the health services to cope, the colonoscopy and the surgical services, to cope with this new clinical load. And this information has now led to an academic publication, but more importantly, it's gone back into the upscaling of the program at the national level. So this is a sort of example I mean by implementation research. And my final example actually goes right back to the Gambia. And the agency started in the mid-1980s a randomized trial of hepatitis B vaccine in this country because the government introduced the vaccine in a stepwise manner. So this is still ongoing, and I remember sitting around actually with senior colleagues. I was brought in to measure the aflatoxin as a potential confounder in this trial. And I remember they were talking about a 40-year follow-up in 1985. So I thought, I'm 25 years old, so looking around the rest of you, I think I'm going to be the only one still here in 40 years' time, never thinking I would actually be back at the agency at this stage. And we had to develop a national cancer registry to make the linkage between the clinical diagnosis and the original trial. Anyway, this has been running its course. But what I want to show you is this paper that's in press at the moment. Maybe now it's come out. This is a cross-sectional study of chronic hepatitis B carriage in the Gambia just 2 or 3 years ago. When we started the vaccine trial, the carriage rates, 15 to 20% of the adults in the Gambia were chronically infected with hepatitis B. But to run the trial, we had to build the infrastructure to deliver the vaccines. And in fact, this became part of the EPI and all the vaccine delivery. And now I think the coverage of childhood vaccines in the Gambia is about 95%. So these are children aged 1 to 5 years old. just under 2,000 were tested, and just 3 had hepatitis B surface antigen, so a percentage of 0.2%. And you can see even in the slightly older children. So in this case, the public health benefits of introducing hepatitis B vaccine are running well ahead of the science. And I think it's a very nice example where, in fact, in this implementation research, you can build the service capacity in some way into the research project itself. I mean, these rates are lower than London in the UK. So this, I think, for me, has been a big lesson about how to build development capacity in with research innovations. So my conclusions, we have this challenge of a rising cancer burden. It's a development issue. It's seen as a barrier to human development, and we can't solve it by high-tech, improved treatments. We have to focus also on prevention and early detection. I think there's a great benefit to be had by dragging some of this modern technology and knowledge about the molecular basis of cancer into interdisciplinary research on cancer etiology, cancer prevention. And I think there's an opportunity as well to apply our epidemiological skills and lab skills to implementation research. And this is, to me, is a crucial step in changing the burden of cancer globally. So we have a duty, as I've put here, of care to both to the patients of today and to the populations of tomorrow. And perhaps one last publicity, I draw your attention to the World Cancer Report, which we released on World Cancer Day, and this kind of is a resource, I hope, for everybody on cancer globally. Thank you very much.
So let's take some comments on the exposome. Oops. You all want to go for the pika pika, I guess. What is your experience from the European governments in terms of implementation of measures? The examples you put were very good.
Another technology challenge. Yeah, it's fair to say I have much less experience in terms of trying to do this type of implementation in the European setting. But in fact, part of my thinking was really changed with, I was on a grant review panel on epidemiology and behavioral science. And one of the projects was on how to get middle-aged men to participate in colorectal cancer screening. And it was comparing two sets of sort of information. So in a Western setting, I think we go very much for these factual kind of information sheets. There are this number of cases per year, and if you detect it early, the mortality drops and whatnot. But this young researcher was comparing that type of information with more testimonial-based things. So somebody famous who said, well, I thought it would be embarrassing, but when I went there, it was okay, and the nurse was very nice and friendly. And I'd never seen cancer research of this type before. So my impression is that the governments are really looking, actually, for this type of research because it's much more directly applicable to policy. I think the danger is in making all research of this type. I mean, we do need to understand what the underlying causes are and the biology of the disease. So it's getting a more integrated approach, to my mind, is important.
Okay. Mark?
You showed a strong relationship with the Human Development Index. And one of the things is my own interest, like urban planning and or urban transport planning. How does that come in? Is there anything related to that what you would see for that come into this as potentially preventable and lead to prevention?
Well, I think this is a really good point, because I think the answer is we don't know why those two map on so closely. I mean, it's certainly one of the cancers for which obesity and physical inactivity have been shown to be risk factors. So you could make an argument that some of that association is due to those trends as well. I think what's interesting to me is whether you can avoid some of the errors of the Western world in these countries that are in transition, because we've learnt this from retrospective studies, but are we actually able to do anything about preventing the same mistakes elsewhere? But I think the short answer is we don't really know what's completely underlying that transition or explaining it. And I think there's real opportunities for research in some of those countries that are in transition, because those differences in exposure, if you like, are much more extreme in some of those populations where there's still a more traditional lifestyle and an evolving lifestyle.
Miguel?
Yeah, you're absolutely right. I mean, the point of proposing this was really to generate a better balance in investments and in research between these two areas, recognizing that the environment and the lifestyle plays out on the back of the genome. So I'm from a laboratory science background, and in the mid-80s, many of us were struggling with biomarkers of exposure, and then we started to genotype things using PCR. And we could get very quick papers, actually, and do it on case control studies. And so I just felt there'd been a neglect on the laboratory sciences to try and help with this improvement. And this was the purpose of proposing this exposome, was a bit of a challenge to say, well, look, in theory, it is knowable. Of course, in practice, it's much more challenging than the genome. And what I would say to the skeptics is, now I see, several million euros invested in this type of research to help us better understand the role of the environment and lifestyle in chronic diseases, and that's, for me, is a success. But I don't see the exposome as being the same utility at the individual level as the genome may be. For me, it's something that we can use as an idea to study at the population level risks, but not to make decisions about individuals' medical treatment or prevention strategies.
Yeah, and in any case, the exposome, as you have described it, and as we have been applying in the projects we're doing and other people, is not only the biotechnological part. It's much wider, and it has, as you showed also in your presentation, it includes a lot of new technology in exposure assessment, not necessarily biotechnology. So, and that's how we have been using the concept of exposome.
Yeah, I think there's a risk of trying to reduce it to a set of technologies and saying that the exposome is the omics profile of an individual. This I would really argue against. I mean, I didn't speak about it today, but I think it involves things like the social, the built environment, the economic status of the family, the social interactions that they have. For me, it's really very broad, and you need a different set of tools to tackle each part of that.
Elizabeth? And then
I was moving away from the exposome. I don't know whether the other topic is about the exposome or not. No, I was puzzled by your slide with the distribution of the predominant cancer over the world, and the fact that prostate cancer was a dominant cancer in sub-Saharan Africa, for example, because we often think of it as linked to sedentarity and various other facts. And I mean, how do you interpret this?
Yeah, I think it was interesting. When I saw this figure, there were two things that really struck me. One was the breast cancer thing, and this resonated with a lot of, you know, I'd travel in the Middle East and all sorts of places, that I didn't think breast cancer was so predominant. And the second was the prostate cancer, and particularly in Africa. And we were just having a discussion actually at the agency yesterday over what to do about this. There was a lot of debate about how pervasive is PSA testing, because some people said, well, Africa must be untouched by this. But actually people working on the ground say it's amazing now how accessible PSA testing is even in Africa. And also when you look at the mortality maps, I mean, if it was just PSA testing, then you would see what you see in many of the developed countries, like in Spain, the mortality is way down on the incidence. But this is not the same pattern in Africa. So I'd thought of it as a Western disease, but I think we've got to think again about this. And I don't know what the causes are. But maybe, I mean, I know that I think in African Americans in the US, the rates are higher than in the Caucasian population. So perhaps there's something to be learned about prostate cancer in Africa. But I don't have an answer at the moment.
Okay, Pedro, then Oliver. Oh, Rafa, and then Oliver again.
Oh, thank you. So thanks for your talk. Rather, a couple of comments and questions linked to this. I was actually quite intrigued by the example that you used about the aflatoxins and how since 2004 you published the paper, but nothing has really happened. And that led you to talk a little bit about implementation research. My proposition would be, one, although they're clearly linked, they're two different issues. And there comes the question. One is, what do you as an agency feel as responsibility, and what actions do you actually take to translate research into action, and therefore how to influence policy, and what activities and how do you see that space beyond research to actually implementation? Because in that sense, operational research and implementation research can be tools around that concept, but it's not actually how far as a researcher do you have to go and try to influence and where possible ensure implementation. So that was, I was interested in your thoughts as to that element, because it is something that within the Institute of Global Health and the current alliance, something that we're trying to develop. Where does research and how far do you go into actually translating that into policy? Second one, linked to your last comment as to global burden of disease and etiology. How good do you feel, how comfortable are you with the estimates, say, of prostate cancer and for other diseases in large parts of the world? Do you feel comfortable? Do you think the data is accurate, sufficiently good to establish priorities? And then my third question would be, from your from IARC's perspective, and given the huge role that you have played on hepatitis B, thinking of poorer populations or so-called developing countries, played a key role on hepatitis B, you've played a key role on HPV. What would be your number one priority from a global health perspective, thinking specifically of the so-called developing countries right now?
So, I mean, these are all, this would be very nice to have dinner and talk about several of these things. I take them in random order, actually. The cancer, so I hope I kept saying estimates with the statistics, but you know, there's a huge problem with the quality of cancer registration in many parts of the world, Africa, Latin America, Southeast Asia, and others. So So one of the things the agency is doing is really working with registries to try and improve the quality and coverage. And we've tried over the last 5 years actually to completely change the approach and set up regional hubs of excellence that we can. Anyway, this is a long story, but the recognition is that in many parts of the world we have poor data. So some of those African countries, there are no data from that country. We have to use data from surrounding countries. And this. But I don't think that would completely change the pattern. But I think some of the rates are clearly, relatively unreliable. In terms of the policy, the research policy interface, so I think this is perhaps a particular question for IARC because we're within WHO, but we're a research organisation. So how far do we go? I think the first thing I'm trying to do is to get a smoother transition between what we do and what WHO does, so or other international policy organisations. So can we already have a dialogue with them before we do our piece of work to see how we could translate this through? So with mycotoxins, I was sat in my office over the summer and I thought, look, I've done 25 years research on this. I'm sat here as IARC director and I've not changed anything. So I now got a dialogue with WHO and FAO. We're having a workshop to summarise the evidence, but for policymakers, but already with a view to them taking this forward into the member states' discussion. So I think there's a lot more we can do by thinking ahead about the users of our science and also packaging it in a way which is useful to policymakers. And so I think there's a lot where I think the debate comes is when do we step over a line into becoming advocates for a particular thing, and that I find difficult question, because I think once you become an advocate, then your science is coloured by the fact that people think you have a particular position to present. So that there's a real challenge for us as scientists there. And the third one was HP. What would I do? So there are two things I'm really interested in. One is what alternatives do we have to mammography for the early detection of breast cancer in most countries of the world where this is not an applicable approach. And we're doing some trials on clinical breast examination, and if I had time, I could explain a bit more to you about that. But that would be one. The second, which we also tried to address at the end of last year, is stomach cancer is, you saw, it's the third most common cause of cancer death. We have a really strong risk factor in Helicobacter pylori. But as far as I was told at this, we brought a lot of people together to discuss this, we still don't know how best to control or eradicate H. pylori to tackle stomach cancer. And it just stands out as a major omission where we know the risk factor. We can treat, but we don't know what's the best at the population level. So these two things for breast and cervical cancer I would put high on my list anyway.
So 3 more questions, one each, Rafa, Oliver, and Josep Maria, and then we'll go for the Pika Pika.
So I'll just put one question. It's probably a bit beyond the presentation, but reading the slide here, we have a duty of care for the patients. Not talking on prevention, but what about treatment? If you're saying that the burden is increasing in low-income countries, but innovation, the science is mainly developed for rich countries, would this be available treatment for this burden of disease, or you have to put the question of advocacy and pushing for policy for new innovation to make it accessible?
Actually, I think there's quite a lot that could be done in terms of treatment already in the low-income countries if there was access to the so a number of the effective anti-cancer drugs are now off license, and some of the things that are very effective at treating childhood cancers, testicular cancer, tamoxifen for breast cancer patients. These I think could be used and at relatively low cost actually. One of the challenges then is, who delivers such treatments, and whether we have to think differently about an only physician-led delivery of some of these treatments. And also some of the cancer screening, the cervical cancer screening approaches using visual inspection with acetic acid. These are being applied in quite effectively in parts of Africa, even though they're not the top-level approach. So I don't think it's that nothing can be done, but some of those things are about access and capacity to deliver.
Yeah, I'm going back, I'm afraid, to the exposome and more basic science, so that's more my interest. What do you think of the promise of these technologies such as adaptomics or metabonomics to generate new etiological knowledge? So sort of going back out from the technology, like in genomics, to find new risk factors that we hadn't thought of.
I really think it's an open question, actually. I'm not sure at the moment whether, I mean, we had a first wave, didn't we, with mutation spectra in P53 gene, and it came up with 2 or 3 exposures, of which aflatoxin is one that could be linked. So the answer is I don't know at the moment, but I think given that the investment has gone in and the technology is there and the knowledge about the underlying biology, it's got to be worth a look. And that's why I was very excited by this renal cell carcinoma issue, because it's the first time we've seen a spectrum jump out that gives us a clue about the cause. So I think it's really worth exploring, and particularly exploiting some of the international comparisons of the same tumours to see whether the patterns are the same, and therefore are the underlying risk factors the same. I think there's a lot we could learn, but it's open question whether it will actually deliver.
So last question to Maria.
Yeah, thank you, Chris. Thank you very much for the nice talk. My question is about research in a global perspective. I think you made a very clear picture of the epidemiological transition and the continuum, the global continuum of cancer. But most of our research still is divided between research in high-income countries and less research in low income. And there are very few opportunities for global approach for research. And which is your view on that? Which opportunities you can envisage in the near future for that?
Well, I think there are huge opportunities, actually. I mean, some of these, for example, the one I just mentioned, the international comparisons of the molecular changes in a given tumour. Let's take a country like Brazil, which is in transition, which has already developed. If you look at their colorectal cancer cases, which are going on the increase, do they look exactly the same as the ones in the US or Spain or the UK? I mean, people are doing international comparisons, but without the epidemiological data. I think it's a real shame. So that's one area. And another is on rarer cancers. I mean, there are some cancers for which you simply can't get enough cases at a national level. And so to study, you really need international collaboration in the rarer tumours. So I do think there are a number of areas. The difference is, certainly in my experience, since I first went to IARC as a postdoc and then left and came, there's actually a capacity to conduct some of that research in the countries, in the partner countries. So it's not just a case of designing a study, implement it, taking all the data and the samples back to the high-income countries. I think there's an increasing chance to have a genuine collaboration. So yeah, I don't know if it's really answered your question, but I think exploiting the differences and the contrasts is still, this was the original vision for IARC, it was what they called in those days geographic pathology. And I still think it's got a lot of molecular geographic pathology.
In terms of funding and commissioning research?
Funding. It must be a director. I think this is a real problem, actually. I mean, anyway, yeah. I think there's relatively few places you can go for this international collaboration. I mean, obviously in the EU we see that kind of cooperation now, but for truly global international, it's difficult. Yeah.
Well, we finished the first meeting of the faculties of Chris Sieben, Creal, and ES Global for the strategic planning, and funding was one of the things that were clearly identified as a problem. So Chris, that was great. Thanks a lot for coming. Bye.